Welcome back to the Ellyn Institute webinar series, Raising Children with Special Needs to be Competent Eaters. Today is the second program in the series of 3. I'm Carol Danaher, a clinical faculty member of the Ellyn Institute and public health nutritionist in Santa Clara County, California. I found last week's webinar extremely informative, and I bet you did too. Already we have a dynamic discussion occurring in the Clinical Issues Bulletin Board. You have all received a link to that. The Ellyn Institute is a not-for-profit organization formed in 2008. The Institute devotes itself to passing on the legacy of Ellyn Satter's feeding dynamics and eating competence models through education, training, and research. If you find today's webinar helpful to you and would like to support more programming like this, please support us by making a donation. You can find a Donate tab on the home page. Today, Ellyn will start again our session, and Dr. Ines Anchondo will present the poorly eating and growing child with Down syndrome. May 10th, our last session, Ellyn and Ines Anchondo will present on the developmental principles as planned. Our speakers today are both highly experienced clinicians who have volunteered their time to bring you this series of webinars. Our first speaker, Ellyn Satter, hardly needs introduction. She is an internationally recognized eating and feeding authority. You are probably here because you know her work. Dr. Ines Anchondo is a pediatric nutritionist at Texas Tech University Health Sciences Center in El Paso. She has worked with families with children with special needs for 16 years. She is also a clinical faculty member of the Ellyn Satter Institute. Thank you, Ellyn and Ines. We are offering a certificate of participation available on the Ellyn Satter Institute webpage. We will email you a link to the certificate of participation after the third webinar. Ellyn, I'm turning this over to you now.
Thank you, Ines. Thank you, Carol. I get all excited here. There are all these things we have to click and do right at the last minute. Okay. No worries, I can do this. Okay, I think you can hear me. I think you can see me, so we're good to go. Hi, everybody. Welcome to session 2 of our Children with Special Needs webinar. I'm glad you're asking for donations. You know, if you find these webinars help and the associated services helpful and are wondering about a donation, consider that even $10 to the Institute helps a lot. ESI works on a shoestring to provide this and other services to children and families. It is a 501c3 organization, so your donation is tax deductible. Last week, I introduced you to feeding dynamics-based assessment, and Pam Estes did a brilliant job of talking about her work with Joseph. To review, in the feeding dynamics model, the parent works with the child and the therapist plays a supporting role. Within that context, the energy for change comes from the child. You don't have to get the child to eat. The child gets himself to eat. This week, I'll talk about feeding dynamics-based treatment, and Ines Anchondo is ready to talk about Luis, her child with Down syndrome. The feeding dynamics and eating competence models trust and cooperate with intrinsic biological, psychological, and social processes. These intrinsic processes support the powerful and reliable tendency to eat satisfying amounts of rewarding food and to maintain appropriate body weight that is unique for the individual. You've seen this, this slide before, and you'll see it again. Print it up, hang it up, print it out, hang it up, and read it to organize your thinking before every intervention. Do read this appendix. It tells a lot more about assessment than I was able to give you in last week's presentation. Also read about the treatment of the child with eating and growth problems. This is This too says more than I'll be able to tell you today. It's about child overweight, so you'll have to sort of adjust your perspective, but I know you can do it. As Pam told you last week, approaching a child from the risk perspectives labels him as being unable or unwilling to eat and leads right into putting pressure on feeding. It's natural to want to help when a child seems to need help, particularly when the child is ill or seems incapable in other ways. The tendency is for adults to become overactive. This robust-looking little boy has cystic fibrosis, and his parents are doing a wonderful job with feeding. Unfortunately, for every child at every level of functioning, being pressured to eat makes them eat less well, not better. I've been amazed at all the control-based, ill-conceived, pressure-laden feeding guidance that goes along with treatment plans for children with special health care needs, and I expect that you have too. Once you complete the assessment that we talked about last time, it's time to sit down with parents and explain to them where the child's eating problems come from. That explanation provides the basis for treatment recommendations. I'm going to have to frustrate us both by showing this to you without discussing it. Then we use this rubric as a guideline for setting the stage and joining with the parent before launching into the details of the intervention. The next issue of Family Meals Focus newsletter talks about this rubric in detail and explains to you how you can use it with your parents. For feeding dynamics-based treatment to be successful, the parent has to be ready, willing, and able to do it. As I said last time, applying the feeding dynamics model for the well or ill child requires consistency, a leap of faith, and steady nerves. Joseph's mother had these capabilities, and she and Pam worked well together on Joseph's behalf. No matter how skillfully you approach them, for a variety of reasons, the parent may simply not be ready to enter treatment. As we all have found to our chagrin, trying to do treatment when the parent isn't ready is frustrating for everyone and counterproductive. You will desperately want to help the child, but without the parent's commitment, energy, and creativity, the treatment simply won't work. Accept and support the parent's decision not to go ahead with treatment. They have good reasons. You've already given them a great service by providing the assessment and plan for intervention. When they're ready and in a different place, they may be able to go ahead with your recommendations. I'll be talking about these points in detail, in more detail, not great detail. More of the divisions of responsibility that are stage related next week. Relative to cues, Marcia Dunn Klein, occupational therapist, author, and workshop organizer, talks about the tilt. When feeding is going well, parent and child are sitting up straight, facing each other. When the parent is being pushy, he's leaning forward, the child back. When the parent is being withholding, the child leans forward, the parent back. Relative to ability, Suzanne Evans-Morris, speech pathologist, author, workshop leader, talks about feeding orally until parent and child run out of enjoyment and energy, then finishing off with a tube feeding. This is essentially what Joseph's mother did. And back to Marcia Klein, who talks about getting permission for doing, for feeding certainly, but also for doing oral desensitization. I will be talking about this more next week. All children are anxious about new situations. Some children are more anxious than others. However, if you set up the situation properly with opportunities to learn and no pressure, the child will master his own anxiety. It may take him a little while, but he'll work with himself and bring himself along. Once the pressure is off to get him to eat, meals can be pleasant for both parents and child, and the child can learn to behave nicely. That is what the parent can accomplish, but neither the parent nor the therapist can get the child to eat. After he learns to behave nicely, in his own way and at his own speed, he'll push himself along to eat. As Pam told you last week, a child will not do, and suddenly he'll do at a surprisingly sophisticated level. The family meal is a central part of the intervention. Of course, with introducing meals, you may also be introducing pressure on the child to eat, so you have to have that off. Good tasting food is critical in supporting a child's learning to eat. Parents have to be considerate of the child's... I'm going to shut up and let you read that. Parents have to be considerate of the child's limited abilities without catering to likes and dislikes. The critical elements are offering a variety of food that is good tasting and available to everyone, and then letting the child pick and choose from what is on the table. The child wants to be successful with the meal. To do that, he has to look over the food and see something that he likes and can eat. Seeing something he likes makes him braver about tackling foods that are unfamiliar. Do be careful not to get into your shoulds and oughts with respect to food selection. Structure is the bottom line. This handout on my website, if you go to How to Eat and then scroll down to this Mastering Family Meals Step by Step and go to here, Get the Meal Habit. This offers a good place for families to get started with the structure of meals and snacks. And it encourages them to eat what they are eating now, just have it at regular meal and snack times. Round up the family and and follow a division of responsibility in feeding. Don't get pushy with trying to make the child eat anything he doesn't want to. And once structure is in place, once families have the meal habit, they'll gradually improve their dietary quality. Toddlers eat butter. They do that to compensate for the sudden drop-off in dietary fat percentage during the transition from the breast or bottle or formula feeding to the family table. Making high-fat foods available supports their ability to regulate food intake. Don't condemn butter. In fact, check out its fatty acid profile. Also keep in mind that the most important dietary principle is getting enough to eat. Parents will be anxious about making changes and need your support. You'll be anxious as well, but you have to contain your anxiety and keep it to yourself. Getting structure in place takes many weeks or even months. Once that happens, the child's eating competence will progress. Conversely, if the child's eating fails to improve, there is a glitch with applying the division of responsibility in feeding. The same reasoning applies to relapse. If the child's eating gets worse, pressure or lack of support are creeping into feeding. Parents will likely put pressure on feeding in many ways that they have developed over the weeks and months of trying to get their child to eat. If you have a good working relationship with parents, they will catch themselves at it and tell you about it, and you can even have some laughs. It also helps for parents to bring in current videos of feeding. Watching them with parents lets them pick up on their own feeding errors. This may be the hardest because it's counterintuitive, but children always do and dare more when they're given autonomy. This is not intended to be manipulative. This is real. And unless your parent really is able to mean it, they probably shouldn't say this. A child will have many ways of sneaking up on food and learning to eat. He may watch parents eat, want the serving bowl by his plate, take a serving on his plate, or touch and smear the food, all without eating. He may put food in his mouth and take it out again, many times. Through it all, parents and professionals have to keep their nerve. Following the division of responsibility in feeding is not for sissies. And now I give you a woman who is not a sissy, Dr. Ines Anchondo. And Ines, I'm going to have to mess about with this for a minute and mute myself. Well, I can't find my mute screen, but so Cleo, would you mute me, please?
Ines? Ellyn, I unmuted you so we can continue on. Ines, we're not hearing you for some reason.
How did we lose Ines?
I'm not sure. Ines, I'm going to quick mute and unmute you from my system. And then, Ellyn, do you have enough to go on with this if we can't get Ines back?
Probably not.
Okay.
Probably not, but I'll do the best I can.
Oh.
Can you hear me?
Yes, and we're glad to hear you.
Okay.
Ellyn, would you like me to mute you briefly?
Yeah.
So let me begin. Can I start now? Okay, I'm going to go ahead and start.
Excellent, thank you.
I want to tell you first the two reasons I'm doing this, and that is because I think that by sharing our stories, we become a community. I also want to show you how the division of responsibility model works with children with special needs. Here is Luis sitting with his mom. This is a recent picture of him. He's 2 years of age, the previous month in April. I've known Luis since birth, but he was not referred to see me until almost 15 months of age. This is the referral. As Carol mentioned, I work at the Paul Foster School of Medicine, Texas Tech University Health Sciences Center in El Paso, Texas. As part of my duties, I cover the neonatology clinic on Monday afternoons and also participate in discharge planning at the new local children's hospital. Luis was referred at almost 15 months to see me, but I'd known of him since birth. This is the first of a series of about 6 or 7 organizing slides that will show up throughout the presentation. Please pay attention to these slides. Although it is not intended for you to follow them verbatim, these organizing slides are more of a blueprint for conducting the nutritional assessment. The most important question is, what is interfering with this child's eating and growth capability? This is the second of the organizing slides. Here are the steps to understand the medical causes and other issues that impair the child's eating capability or give the impression that the child is not capable. For Luis, all of these factors were important, starting with plotting his growth in a way that could be understood in the right context. Also crucial was understanding his motor oral skills and developmental status.
Luis was born at term, but his parents were not aware of the Down syndrome before birth. Luis had significant heart disease, comprised by ventricular septal defect, the atrioventricular or atrial septal defect, patent ductus arteriosus, and biventricular hypertrophy. Luis had cardiac lesions identified as acyanotic, left-to-right shunt malformations, which impact weight more than height in the early stages. Other medical relevant facts about Luis included hospitalization for bronchiolitis at 8 months of age and heart surgery at 9 months of age, which took a long time for him to recover from. Overall, Luis had done initially well. He had a little bit of feeding problems at the beginning at birth, but improved and was discharged home feeding fairly well. At 7 months, he was in many ways a typical Down syndrome baby, except he has a very significant cardiac condition that put him at extra risk. At this time, his ages and stages questionnaire score was 40 to 45 out of a maximum of 60. The ASQ is a developmental tool. He also, however, had very poor muscle tone and poor coordination, both characteristics of babies with Down syndrome. At 12 months of age, he had very delayed in gross motor skills. As I mentioned to you, I've been aware of Luis because of covering neonatology clinic, but the proper referral was not made until he was almost 15 months of age. This time, this is what I observed. He was not walking or crawling. His movement was not a lot. He would sit up with a lot of support. He would hold his head, but where I noticed the most delayed was his cognition, communication, and social emotional development was really the age of 3 to 6 month old baby. This is a growth chart for Luis. It's a Down syndrome growth chart, and this shows Luis was growing slow and low for his weight, but also note the height increase on this growth chart around the time that Luis's weight slowed down. This chart shows Luis's weight z-scores, weight for age z-scores. And Pam talked to you about z-scores in the previous webinar. Note his weight for age was on the left side of the curve. His weight did not begin to improve until after the heart surgery. This chart is important because it shows clearly the issue with his weight, the magnitude of the drop and recovery after surgery was missed, or could have been missed if you just looked at the Down syndrome growth chart. This is the third organizing slide to look into the extent of the child's status with regard to each of the developmental stages. Looking specifically at how Luis was doing at each of these developmental areas, he was working at most of these, even at the age that he was at, more than a year of age. But in particular, separation individuation was interrupted and delayed due primarily to his lack of physical capabilities. The psychosocial assessment showed specific issues with the family. This is another organizing slide. These questions aid in shedding light to specific issues parents may be dealing with, and these issues may affect the child's eating capability. The psychosocial evaluation showed that parents were very young. This is a very young family. Mother really did not understand the issues with Down syndrome, the issues with poor muscle tone, poor coordination, the health problems including Luis's heart condition, delayed development, the different growth pattern, and different in cognitive abilities. The father, I knew there was a father, but he didn't show up for clinic appointments, but I knew he existed, lived with mother and child, and supported them. The mother's main support system was across the border in Ciudad Juarez, Mexico, where conditions have deteriorated so much by severe violence and that the environment is very disruptive. For Luis, this is their parents, this is his parents' first child, and also being not aware of the Down syndrome played a role. There were several missed appointments to clinic for medical and nutritional care due to these parents' situation and lack of organization and inability to understand Luis's situation. On the U.S.-Mexico border, it's not as easy to deal with these issues, as parents can just leave the country and come back only when they perceive they need help. For the child, for Luis, these were the issues. He was socially immature, behaving more, as I mentioned to you, a 3 to 6 month old baby. And also there was the fact that mom felt frustration over the fact that all their children were advancing and Luis was most definitely not in her mind. Mom thought Luis was just not getting it. She would say he doesn't get it, that he needs to learn to eat. In her opinion, there was something intrinsically wrong with his approach to it. This is another organizing slide to address specifically the distortions in nutrition and food selection that may contribute to a child's lack of capability with eating. And these issues continue here. This information ultimately will help in examining the potential distortions in nutrition and food selection that may contribute to the child's lack of capability with eating. For Luis's case, this is what I gather in examining the food record intake. This is the caloric content. And also, mother would offer oatmeal with apple juice every single day in the morning. She would say that he would eat about 2 to 3 spoonfuls, and then that was that. And it was never clear if he was hungry or not, if he would eat it or not, if he liked it or not. Mother tended to offer only one food per meal or snack, because in her mind she thought that this will help Luis concentrate on that food. She felt that if she could only find that magical food her child would really like, then he would start eating solid food. It was something like she would find that to jumpstart the process. She thought it was up to her to find that and make her child eat. She felt that this is a failure of her parenting and not what was intrinsic in with Luis. Luis's feeding capabilities were limited. His poor muscle tone and poor coordination was making it hard for him to progress in his eating capabilities. In terms of energy expenditure, Luis would move very little, so he had very little control of his body. I think of all babies that I've seen with Down syndrome, Luis has to be one of the most extreme in terms of poor muscle tone and lack of coordination. In addition, Luis was not interested in drinking from the cup, the open cup, or sip cup, or eating solid food. It was clear that Pediasure needed to be the main source of nutrition for Luis. Tube feeding at this point was discussed with the mother as an option, especially to give it to him overnight, but she refused it because in her mind, Luis had already experienced a regression from the time of the surgery, and to her, tube feeding was moving backwards instead of forward. The feeding dynamics assessment showed that probably mother's report were not completely accurate. Something was missing. Mother was offering food constantly. She would also insist that something was wrong with Luis's swallowing. She thought that, of course, something was wrong with related to coordination and muscle tone, but in addition to that, she thought that Luis's reaction was too strong whenever she put food in his mouth by surprise, either because she would sing and he would open his mouth and she would put food in there, that he would just, gag in a way that was very strong to her. So there was a swallowing evaluation that showed that his swallowing was normal, even in, considering his poor muscle tone and coordination. Regarding the inaccuracy of mother's report, this is the reason why a video can be so helpful. A video of the feeding or several feedings is possible. A video is not so much helpful to the clinician as it is to the parents. I find myself most times when I get a video from parents just sitting back and nodding and just being there supporting the parents' discovery, the moments of discovery that they may experience, and catching their own issues and mistakes in feeding. Video is diagnostic in so many levels, especially in promoting a discussion of the issues and empowering the parents to make those changes. Of note, again, I want to make sure that you understand, mom was the main caregiver. Luis' dad was not involved in the feeding, although he was present. He was not involved in the feeding or the daily care because he was working. Bottle feeding was interesting for Luis. My notes at the time read, feeding is awkward as mom tries to check constantly how much Luis is drinking. But she cannot really see what he's doing without disrupting the feeding. She holds him with his back against hers for support. She does it against her chest, so he would be more supported. This makes her miss feeding cues, so she would interrupt the feeding to try to see what was going on. Since we didn't have a video, at one point I brought in a mirror for her to see herself. This is a description of how spoon feeding went with Luis. Mom was very anxious and nervous, again, thinking that there was something she could do to make him eat. To encourage Luis to eat more, Mom was following the advice given to her by another therapist, and she was told to leave food in the play area. Apparently, I've heard this from several parents, especially lately, so maybe this is something that is new. And people are finding that may be helpful. So she was told to leave food in the play area or near where he was, so he would find it and accidentally feed himself, accidentally, quote unquote. Mom was also singing to him to make him open his mouth and distract him. She also told me that she thought there were some sensory integration issues, or somebody mentioned it to her. She would say seemingly contradictory things like Luis cannot tolerate certain food textures and prefers soft and sweet food. But at the same time, she would say that Luis would love eating unsalted crackers, which are not, as you know, sweet or soft. Mom also, again, I want to remind you that she thought that the Down syndrome manifested as Luis didn't know what to do with food. He didn't know that by eating he would feel better. This is a summary of my impressions. Medically wise, by the time I started consulting with him or with his mother, his weight gain was adequate. The heart condition was surgically cured, and Luis had started to gain weight. Nutritionally, mother thought again that Luis had this associative thoughts with eating and feeling hungry, and that his signs were not too clear. Again, she thought, quote unquote, that he didn't get it. And a swallowing study confirmed that his swallowing was fine, but in the back of her head, she would thought that something was missed. She also expressed several times that she was very, very frustrated because, in her opinion, Luis was doing better or in terms of eating solid foods before the surgery. Clearly, Mom needed support in acting the division of responsibility to trust the progression to solid food. Psychosocially, Mom kept expecting Luis to recover faster from the surgery and act normally, whatever she thought that was normal. She didn't understand, again, the issues involved with Down syndrome, the poor muscle tone, the poor coordination, and how much this played a role in what Louise is capable of doing, and hence being able to eat. Feeding dynamics, there was this disconnect between what the mom was expecting and what the child was able to do. She needed to understand better the issues with Down syndrome and specifically Louise's situation. Again, as I mentioned to you, even as a child with Down syndrome, Louise was at a more end of this, spectrum, as extreme case of very poor muscle tone. This is a zoom-in slide that shows you the growth chart, the Down syndrome growth chart for Louise. And it shows you in detail what was happening with the weight at each important point. The mother was introduced to the division of responsibility, and it took her, a good amount of 3 months to begin to enact it fully. And you can see what happened with his weight during that time. So, in conclusion, it is not about low weight. It is not about getting food into the child. It is all about understanding what are the issues. And in this case, it was Louise's developmental delay in gross motor skills that was was the root of this problem. This is a handout that I use in this case. It shows what children can eat at different stages based on capability, not so much on age. I think it's perfect for children with special needs. In some children, this corresponds to age, but in special needs children, most often it does not. And also, progression timing might be different for children with special needs. In understanding what happened with Louise, it's important to bring you back to what level of care was provided. A lot of families can do secondary intervention, but Louise's family needed tertiary intervention because these families cannot enact the division of responsibility in feeding until they resolve underlying issues. So it is not that the intervention doesn't work. It is not that the parents are not compliant. It is the whole circumstance that is making these families need another level of care. Those issues may be situational. In this case, this family deciding where to live, and also other overwhelming life circumstances. In Louise's case, the severe heart condition. So these families may need casework before they can provide for the child and begin to act on the behalf of the child. You've seen this slide several times. This is the last of the organizational slides I will show you. This slide presents the steps for treatment using the trust model, operationalizing the divisional responsibility in feeding. And it applies perfectly for children with special needs. This slide shows the steps for the treatment for Louise. These were the parents' jobs. Absolutely, they had to sit in disease, all force feeding or playing tricks or making Louise accidentally feed himself or feed himself without thinking or intending to. Louise had to be able to choose eating on his own volition, knowing what that meant. This is another handout that I use. The emphasis is to match the ability of the child to the step that is showing here. It's not better step 4 than step 2. It's just where the child is. And I think by not having ages, it's also helpful for parents to see what they can do to help their children choosing better foods to feed. These are the tasks or jobs that Louise needed to work on. Perhaps the most important one was to become more toned and coordinated and improved in his own development. This is a summary of the treatment plan for Luis's family. Luis's mom came for weekly and every 2 weeks appointments for about 6 times in a row in a span of 3 months. We also talked on the phone during that time. Every session, we began by reviewing what Luis was able to do and what he was eating. I felt this was very important for Mom to recognize where Luis was, enjoying the child she had versus the child she wished she had had. And even, through the time, I was able to see how Mom was being more and more attached to Luis. We also talked about progress, and I helped her see for herself what exactly meant for Luis. We reviewed behaviors she was doing that could be interpreted by Luis as pushing, or just making sure that she was able to see what Luis would do with the process. Mom began to see Luis started to be interested in foods as soon as she established and followed meals and sit-down snacks at the table. She was also able to begin to trust Luis that he will develop an interest in food as he began to develop better, began to gain more capabilities, was able to sit without support, and even began to crawl. She offered Pediasure with a meal and snack to make sure Luis met his nutritional needs. At times, she would not offer the Pediasure. She would withhold it, just to entice it, to see if he would at least try one food. This is contrary to what I recommended, but she would from time to time go back to wanting to do this. This didn't work, and we discussed it at the sessions. Another thing that helped was offering Luis different food at different meals, not just one food, and keeping in mind that his physical abilities keeping in mind his physical abilities to offer food that he could eat. Further improvements related to Luis improving physically and development, and with Mom following the division of responsibility. Now, Luis is 24 months of age. He's eating 3 meals a day of lumpy food. Sometimes he has a snack mid-afternoon. He's now accepting more crunchy and finger foods. He sits in a high chair and continues to drink Pediasure about 4 to 8 ounces per day. Sometimes it's a little bit more. He's also learning to drink from an open cup. This is another handout that I've shown this mom because I thought it was important for her to take care of her own eating, being that she was the only caregiver for Luis during the day, even with the help that she had from her extended family. So I thought it was important for her to see that eating had to be done in a certain way so that it would follow through the day. She needed to make sure that she had meals and share them with Luis, and not just feed Luis and forget, or just grab a snack or food on the run for herself. I think it's time for Ellyn to come back.
Wait, if I can. Okay, I'm unmuted. So, okay, thank you for unmuting me. I have such a noisy microphone that I create disruptions. So we'll come to questions in a minute. To prepare for next time, I have some suggestions for you. First of all, and I'm going to take you to the ESI website to do that. Here we go. We are at webinars, webinar handouts, and so for session 3, I would encourage you to print out this handout for yourself, this Developmental Principles Guiding Feeding Practices. And this is derived from Child of Mine, and I'll be going through this in detail next time. Last week, Pam told you about, reminded you of what your baby can do and how and what to feed him. This too is from Child of Mine. I'm going to be, with our reorganization, I'm not going to be able to spend as much time with the eating competence as I was planning to. I was planning to do a repeat of a lot of the information from this session 1 of the Preventing Child Overweight and Obesity webinar. That's where I talk about eating competence, and I'm not going to be able to do that. Oh, and one thing I did forget to tell you, Ines is showing you parent handouts today. Feed the Way Your Child Can Eat. These are also on the ESI website. And this is the parent handout. The other one that I'm going to be showing you is in quite a bit more detail. But these talk about stepped food, like step 1 food, step 2 food. I sort of stole the idea from the baby food industry to put that together. And then here's eating after the baby, and Ines didn't tell you this, but that's Ines and her family. Is that all right, Ines? So, okay, so that's what I suggest that you get ready to do next time. And here are the 2 handouts I'll be using especially. I agree with Pam from last week that Child of Mine is your best reading. And seeing the new video, Eating with Love and Good Sense 2, I think could be really helpful for you. In fact, there's a parent package, parent education package that this is contained in, and that's actually what I recommend you get, but I'll tell you about that next week. So, having said that, we are at questions, and I think we actually have a nice length of time for questions. Cleo has been perusing these, and she's going to be giving them to Ines and me.
Excellent, and I want to let people know, thank you, we've had a few discussions going over the questions board, and I think I posted this, but I want people to know that is me handling the questions. It's not Ines and Ellyn. They're not able to read those while they're going, but we are keeping track of everything that you are saying. If we don't have time to get to your question today, please don't worry. We have a clinical issues board where you can post that we'll talk about in a few minutes. But in the meantime, we have a couple of questions that have come in, lots of good comments too, and I would also encourage you to post. Some of you are posting about your own children with special needs, and it sounds like there's some good discussion there, so please do consider posting that on the clinical issues board as well. Okay, Erin would like to know what specific resources you recommend for families that need tertiary support following the division of responsibility.
Well, I'll start answering that question, and then Ines can pick up from where I left off. In doing tertiary support, let's see, where is that slide? Yeah, can't do it until they resolve underlying or contextual issues. Louise's family had social issues for which they required casework. They needed help deciding where they were going to live and getting themselves settled in the new place. Louise had medical issues, and that had to be resolved. He needed to have quite a bit of medical support, and he needed surgery. Sometimes families will have psychosocial issues, you know, that they'll be particularly, or the parents or the family overall will be particularly rigid, so rigid that they can't give the child autonomy with respect to the division of responsibility in feeding, or they might be so disorganized that they can't get organized with respect to structure and see to it that the child gets that structural support that they need. So, Ines, what do you have to offer to that?
Well, you know, depending on where the child is, and depending on the community, I think that you know, involving a social worker is crucial, and I don't know, here in El Paso, I think we're starting to become more organized on how to deal with these issues. But different communities have different agencies that can be helpful. Early early intervention programs can be very helpful in that sense. But I guess, like I said, starting with involving a social worker can be very helpful.
Good. Pardon me, you know what, I'm going to try this name. I probably shouldn't, but Miharu is asking, if one parent is ready but the other is not, what will you do? I have several parents who are in this category for one reason or another. One parents believe in the division of responsibility, the other disagrees, etc.
Mm-hmm. Well, I would put that, I would send parents home with the recommendations and encourage them to arrive at a meeting of the minds before they try to go ahead. Because the, you know, whether even if they try not to, if one parent tries to enact division of responsibility and the other one doesn't believe in it and is going to be pressuring or restricting or giving the child food handouts in between meals, that's really going to undermine the treatment overall. And so my inclination would be to do the assessment, to make the recommendations, and then encourage the parent to think about it, work on it, get some outside help to arrive at an approach, at an agreement on the treatment plan before they come back to see you. Because if you're going to be in the middle of trying to negotiate between these two parents, it's going to be very hard on you, and it really isn't going to help the child. But Ines, what do you think about this interesting question?
Yeah, I agree. I definitely think that parents need to make that decision for themselves. That they need to, in a sense, you have to enact your own division of responsibility with the parents in you know, do your jobs and let them do their jobs. And if they're able to work together on behalf of the child and do it with you and doing this kind of work, they're going to need to find their own, you know, their own help.
Yeah, and you know, it's very hard because, of course, we want so desperately to help the child, and we can see so clearly what's needed in order to bring the child along, but we just have to let go of it. So, Cleo, go ahead.
Okay, Suzanne would like to know, and it's Suzanne Morris. I wonder if this is our very own Suzanne Morris. How do you guide parents in supporting children's awareness of hunger and desire to eat when there are gastrointestinal difficulties? Many children who are on medications for GERD are very unaware of hunger signals because the discomfort signals, or at least memories of those signals, are much stronger. So how do you guide parents in supporting children's awareness of hunger and desire to eat?
Well, Ines, do you want to take first crack at that?
This is one of the things that I work with parents with special needs and other parents as well, is reviewing the child's signs of hunger. And it's completely, you know, right. Some children may not be as demonstrative of their hunger, and what I think what's important is to help the parents understand where they're coming from, and then if for instance, depending on the timing of the medication, some children have more symptoms, you know, of not showing. I'm calling symptoms of not showing signs of hunger for breakfast, for instance, and I say focus on lunch and in a meal that is later or during the day. But I do encourage the parents to look at the child, to see their faces, to notice what's happening, and do it in a way that is non-intrusive. But I've never experienced a child that shows no signs of hunger, even though the parent thinks that there's really, the child just eats because, you know, it's kind of automatic. But in my experience, helping the parent go through the signs of hunger and a lot of the times as I describe them, the parent begins to say, yeah, I think I've noticed that, or the face color changes, or the child is sitting, it's sitting eagerly close to the table and it sits back. There are a lot of signs that the parents can notice.
So it's more atypical signs than no signs in this.
Yeah, but different. But all children, do it. And like I said, it depends on when the medication was given. For some children, that makes a difference.
Yeah. Well, okay. So more subtle than atypical.
Yeah.
Mm-hmm. Okay. Cleo?
Janet would like to know, is this feeding program done as a team? And if so, who are the team members?
Okay, I wish. I have to answer that. I wish. I guess I kind of have a team here, but I also work on isolation. In isolation, a lot of times. But like I said, it's my hope that with the new Children's Hospital we begin. It's ideal, I think, to do it with a team of people that can help and support the parents in the different issues. But no, you don't absolutely need to have a team.
I'm going to answer this. I'm going to jump ahead, Cleo, and talk about our clinical issues bulletin board, and then I'll circle around and tell them how they can get on it.
Oh, good.
But you're all invited to be a part of this clinical issues bulletin board. And we have a post. This one, is that the one working with feeding therapists? And here is a speech and language pathologist who talks about what it's like to be a good team member with the feeding dynamics model. And she talks about kids with motor-based issues have negative experiences with choking and so on. And so I think this approach, helping the child learn how to control the food in their mouth, how to, manage food, the path of food in their mouth so they don't choke. All of these issues would be the sort of approach that would team very well with the feeding dynamics model. Okay?
Good. Okay. Stephanie asked, and I'm glad you addressed that. There's been lots of questions on the board. I'm just going to throw out there, somebody asked, can anybody use that board? And yes, anybody listening to this program, or if you know someone else you think would benefit from that board, they're welcome to go there.
All right. Now I'll show you how to get on the board. I was going to do that when I was mucking about. It's under webinars, Cleo?
Yes, you can get to it from several places on the ESI website now.
All right. Here we are on the ESI website, and here's Clinical Issues Bulletin Board. And here you can probably barely see it, but it shows you where you can sign in as a user and assign yourself a password. And from there, you can just go ahead and start posting and participating in the discussion. And let me give you a quick, you see, you go to the board, and here's how to use it, here's where you post, and then you just can give yourself a new topic, or you can join in with any of the other topics. The last person who posts is indexed here, and let's just look. Here's there's a string under Santa Clara County. Here's something with Carol Danaher, feedback from me, feedback from Pam, and then Carol Danaher again. So here I am being quiet, letting somebody else talk.
All right, I think we can sneak in one more question. I see this is posted from Carol, so probably someone from her group. How do you guide parents in supporting children's awareness of hunger and desire to eat when there are gastrointestinal difficulties? Many children who are on medications for GERD are very unaware of hunger signals because of oh, I'm sorry. I am reading the question I read earlier. Sorry about that. How do we deal with children of special needs with eating too much when they don't get feeling of being full and they overeat too much?
Okay.
So
Ines?
I think I've never had that case other than Peter Willie. With those families, enacting the division of responsibility in feeding can be even more helpful, because by allowing the child to eat and decide how much and whether at meal times, I've seen that these children begin to come down about eating and begin to eat in a more regular fashion. So my experience has been that the division of responsibility works and works well with these children.
Mm-hmm. So, and as it certainly is the case with children who do not have special needs, that if you try to get them to eat a certain amount or restrict their food intake, they become food preoccupied and tend to overeat. And then, you know, the thing to do about it is restore a division of responsibility so they won't be afraid anymore. And I think I hear you saying this is the same for children who have special needs.
Absolutely, yes.
Yeah.
well, we're just at 2 o'clock, so it's time to wrap up. Thank you, Ellyn and Ines, so much for volunteering your time and your expertise today. The Ellyn Satter Institute is very pleased to be able to bring this information to you, and we're really looking forward to seeing these discussions grow and develop on the board. Again, there were so many good questions. Sorry we didn't get to them all. And I just want to say once again, several of you were posting about your own children or your own case studies, and we'd love to be able to have that discussion with you online. Again, a quick housekeeping note. We're going to be sending out a link to a completion certificate after the 3rd webinar, and that completion certificate will give you opportunities to show what you've done and to give yourself credit for pre-reading and some of the other activities you've done again. So look for that after the last webinar. Thank you so much for your support, and we will look forward to seeing you all next week.
Bye, everybody.
Bye.